Megan Ellis. As he mentioned, I'm going to be talking a little bit about osteopathic medicine today. And there's actually only going to be 3 of us. Our 4th fellow wasn't able to make it, but I can let these guys introduce themselves as well.
Hi, everybody. My name is Gabe Berenbeim from Colorado. I went to school at the University of Denver, and it's good to be here. Thanks.
Hello, my name is Isaac Metzler. I am from Green Bay, Wisconsin, and I went to the University of Wisconsin-La Crosse on the west side of Wisconsin.
And again, I'm Megan. I didn't mention where I'm from. I'm actually from just outside of Rochester, Minnesota. And then I went to college at Wartburg College, a small liberal arts school kind of in the northeast corner of Iowa there. But I suppose we can kind of go on to our presentation from here. I'm going to try and figure out if I can make sure I can share my screen. It looks like not able to. It says host disabled participant screen sharing. So is there something on your end that you
try it? Try it one more time. I think I fixed it.
Okay, let's see. There we go. Thank you.
Yep.
All right. Are you able to see my PowerPoint at least from here?
Yep, we can see it.
Yep.
Great. And can I try this one? I'm not the most tech savvy, so bear with me. All right. This one?
Oh, she's fine. That's what they see.
Do you guys see the display view or just the full PowerPoint? Like, can you see the slide 1 of 10?
Yeah.
Yeah, it's just it's not like slideshow mode or anything.
Okay, let's go like this. There, that looks a little bit cleaner. So today we're going to be talking about, what is the osteopathic philosophy and kind of giving you a brief explanation on that. Samir did a nice job of introducing what we're going to be talking about a little bit, and what I'll be doing is explaining what exactly is osteopathy and why we use it, what it means to practice osteopathic medicine, and then we're going to give a little bit of introduction on what we do as fellows here at Des Moines University, followed by a short demonstration. So in order to explain, what osteopathic philosophy is, we like to break it down to 2 simple sentences. Regardless if you have a background in medicine or not, you'll be able to understand what it is. So for every medical diagnosis that a patient comes in with, regardless of the disease or injury, there's actually another medical diagnosis that's hidden in the form of an actual twist or turn in the body. And this twist or turn can actually contribute to, or sometimes this twist and turn can even cause the medical diagnosis that this patient came in to see you for. In osteopathy, this twist or turn is referred to as a somatic dysfunction, and somatic dysfunctions can actually only be diagnosed with your hands. These twists and turns can't be seen on imaging, you can't see it on blood work or lab work, only with your hands, and it can only be treated with your hands. And so that's one of the lucky things that we get to do every day, is place our hands on patients and find these twist or turns called somatic dysfunctions. This reason of having somatic dysfunctions, boiling it down to how they contribute to medical diagnoses, is what makes the osteopathic philosophy different than, say, the allopathic philosophy. And our founder for osteopathic medicine is known as Andrew Taylor Still, and he was in fact an MD who was able to find these twists and turns with his hands and is able to pass these treatments that we'll be showing you guys today on for generations. OMM is what's referred to as osteopathic manual medicine. And it's not just another tool per se that DOs have. It's actually an integral part of medicine. When we go to osteopathic school, DO school, we're learning the exact same things that a medical doctor, an MD doctor, is learning. But in addition to that, we're finding these twists and turns after first figuring out what the patient's medical diagnosis is. So doctors who practice OMM need to know medicine, first of all. And it's not just DOs that can perform OMM. We actually have MD residents who will come to the clinic to learn this osteopathic manual medicine so that they can further help their patients as well. All right. And so just a breakdown of even how it works for a physician in general when they see a patient. The first thing you do, general medicine, is you need to figure out what that underlying medical diagnosis is. From there, you need to do the appropriate medical workup. whether that's prescribe the patient medication, send them off to surgery if they need something like that, or another treatment that's going to be specific to that medical diagnosis. And then after that, we need to figure out what are some of those somatic dysfunctions that could be contributing to this medical diagnosis? Where are those twists and turns in the body that could be causing it? When the body has, an infection or any other underlying medical disease going on, there's going to be a response within those tissues. The tissues aren't just going to remain the same. You're going to be able to feel those changes with your hands specifically. And then once we find those, we can actually treat the somatic dysfunctions from there. And then if the medical diagnosis continues, we might be able to slowly peel back the layers of these twists and turns that might be present and continue to treat the ones that we find or refer the patient on after we've finished treating them. From there, we can do a follow-up appointment to see how the patient responded to the treatment. As I mentioned, when you're treating somatic dysfunctions, sometimes other ones can pop up after you alleviate tension in one tissue area, another might pop up somewhere else. In addition to that, it's also good to follow up with your patients regardless. If you did prescribe a new medication, you want to see them back and see how they're responding to it. If you had your patient have surgery, you want to see how they responded to that. Are they tolerating the post-op pain okay? All right, so that's essentially wrapping up kind of the osteopathic medicine there. But then I'll kind of give Gabe the reins here.
Sure. All right, so we're just discussing what does it mean to practice OMM. And so osteopathic manipulative medicine or manual medicine, as you guys will hear, doesn't mean that, you'll be a fully licensed physician, and you're trained to do, if it's surgery, you could be a surgeon. If you're an orthopedic surgeon, you'll be working on bones. If you're a cardiologist, you'll be working on cardiology. So you still are practicing medicine in whatever field you so choose. So sometimes the appropriate treatment is to provide a drug. Sometimes the appropriate treatment is to provide surgery, right? So you do whatever is the standard of care. Sometimes you find that this is not a case where drugs are the most appropriate. Maybe surgery is not appropriate. And so you're kind of sometimes left twiddling your thumbs. And those times sometimes are moments where you can just provide OMM. In any scenario, however, OMM is always an option. And it just really depends on what is required of you to help this person heal. Which ultimately means that you need a medical evaluation. You need to be able to guide your treatment and your judgments based on what you have medically determined this person to have. And so that's always the case. It's always the case. And so if I threw at you guys like back pain, for example, if someone has back pain, then it's pretty standard of care is to take a history, do a physical exam, and determine why. If it's because they have a kidney stone, well then we might need to move on to other procedures or medications to help alleviate that kidney stone. And perhaps OMM is not the right thing to do at this moment. Or if it was considered something that just related to a torn muscle or a tear, a small little tear in the muscle, maybe you don't need as much, and so you could just do OMM and offer that, or you could do both. And so that practice of seeing the body as both having a medical diagnosis and this twist and turn or the somatic dysfunction is ultimately the practice of osteopathic manipulative or manual medicine. And really only DOs are trained in that because we're the only ones trained to diagnose and look for somatic dysfunctions. And so if you're not treating those if you're not treating those somatic dysfunctions, it's good to refer that patient to someone who does. And that's ultimately would be still practicing under the vein or the veil of OMM. If anyone has any questions, honestly, too, by the way, you can interrupt me. It's no problem. So moving on to just kind of be specific about Des Moines University. Most DO schools require 50 hours of OMM training during their didactic years. Didactic years means the first 2 years in medical school. So just as a general rule of thumb, medical schools are 4 years. The first 2 years are didactics, right? You like go to lectures, you do various labs at school. The other 2 years are rotations, and that's when you're out working at a hospital or a clinic. And so at DMU, we have over 200 hours of OMM, and then we also have extracurriculars. So it's about 1 hour of lecture a week, sometimes 2, and then an hour and a half of lecture every week, both first and second year of medical school. And so just speaking again specifically to DMU, some of these things have been a little tweaked because of limitations with COVID, but generally we've established a relationship with the Drake University and the sports and track and field athletes there. And so they'll come about once or twice a month, and you can treat the students that way. It's an opportunity to figure out how to integrate a history and physical and utilize your OMM. There's an Amish community that's pretty prevalent here. I'm sure you guys are aware of. So they would come here about 1 time a month as well, get to work on them. And then we host marathons or 5Ks that we treat at the end at the finish line ultimately. And then there's always teaching opportunities to be a TA, or which is it's a teacher assistant. It's like a misnomer. You're basically helping out with the labs as a student. And then we got the fellowship. So that's what we're in, guys. So when I said 4 years in medical school, it could be 5 if you decide to do a fellowship. The way we have it here, so you do your first year of medical school, cool. You do your second year of medical school, sweet. And then at the end of that second year, you're gonna take your boards. So that's what that means, take first board exams. Then you're gonna do your third year of medical school. And that's gonna be out in your rotation, wherever that is. And then you're gonna take your second board exam. And then you do an entire year of the fellowship back here at Des Moines University. And then you finish up your 4th year, 5th year. For us, a typical day is we come in the morning, see patients, work with the docs, and we treat in the clinic from about 8 o'clock to 12 or a little past, shovel some food down our face, and then make our way to the labs. And we teach labs pretty much from 1 till 5:30. And in between any of that, on any day, we might be giving a lecture. So that's to the whole class, either first or second years. And we're doing research as well. So those are like 3 major things: teaching, clinic work, and research is principally what we do with our time here. You guys can ask as many questions about that, I guess, at the end. So I think we'll do a demo for you.
So now, yeah, we'll go ahead and do a demo for you guys. I'll do a few treatments. At any point, if you have any questions, I think I'm going to do 2 treatments and see how it goes. Typically, this would be, the first one I'm going to do is looking at the hamstrings, okay? This would be anything from a patient coming in with back pain. If they say that, you know, they're a competitive runner and they're just having a tough time when they're running, that feels like their hips are locking up on them, or anything down the lower extremity. So knee pain can even be, hamstrings can be contributing to that. And so we typically learn about 6 to 7 different treatment techniques. And I'll just be using one of those. If that technique doesn't totally get rid of the SMAC dysfunction that's there, I can often pull a different one in and use a second one to try to totally rid the body of any asymmetry that's going on, okay? So the ultimate goal is to relieve the body of any asymmetry, and you can do that in whatever way you want. Just a general overview of treatment types, we kind of break them down into 2 different types. There's an indirect and a direct. The indirect form takes tissues into the position of ease. That's where it wants to go, okay? But then when we're working with direct treatments, that takes the tissue into the restrictive barrier or away from the position of ease, okay? And so I'm going to use one that's actually 2 of them that are direct. I'm going to be forcing the tissue in a different way than it wants to go, but I will be correcting whatever tissue is holding that asymmetry in the body, whatever tissue that's holding that somatic dysfunction in the body. Okay. Any questions with that?
Really quickly, is there any way you could stop sharing your guys' screen for a while so we could see you in full screen?
Absolutely.
While you're doing the demonstration?
So we will stop the share. And then you guys should be able to, we're going to switch to a different camera that shows a little bit of more what's behind me. And that's an OMM table that we have in lab and the stage that we typically use when we're treating patients.
Awesome, thank you.
Mm-hmm.
Already did it.
Okay, so you can see Megan up on the table. She's going to act as my patient. This might cut off my head a little bit, but that's okay, as long as you guys can still hear me. So like I talked about, hamstrings can be affecting anything in our lower back, our hips, down our lower extremity, okay? And so I want to make sure that her left hamstring and her right hamstring are around the same length. If there's an asymmetry, it can cause some of this unevenness in the body, which could cause some of the pain that she came in with today. So I'll check this left leg first. I'm going to stretch the hamstring to check it, okay? So that's pretty tight. Now I'm going to check the other one to compare, and that one just keeps going. So you see the difference in that, where one side was definitely tighter than the other? Well, that's a great indication that there's a somatic dysfunction going on in that muscle, and I want to make them symmetrical, okay? So I'm going to work on this left leg to stretch out that muscle to hopefully, at the end of this treatment, make it symmetrical, okay? So to do that, I'm going to use a treatment that's called muscle energy. I'm going to stretch that muscle, okay? That's a pretty good stretch. Then I have her push against me. So I'm going to have her bring her leg down towards the table. I count out for about 3 seconds that she's activating that muscle. I have her relax. I wait about 2 seconds to relax the muscle on its own, and then I stretch it a little bit more, okay? And then I go through this process another 2 times. So I'll have her push against me and relax. Let it relax, stretch it out a little bit more. Then I'll have her push against me one more time and relax. And then I stretch it out to the last barrier, we call it. So you notice how the start to my finish was a lot different? Well, I'm actually using the principles of muscle energy to relax this muscle. So I check this right side, which was the side that didn't have an issue before. And then I check the side that I just treated. Look at that, it now matches on both sides. So I suspected that this back pain that she was having could be due to that hamstring. I saw that there was a somatic dysfunction there, and I corrected it. Now the rest of it's going to be up to the patient. When they come back for that second time, you know, maybe I also tell them, okay, when you're having this pain, go ahead and take Tylenol or ibuprofen. And then I want to see you back in a few weeks to see how you're doing, making sure it's not going to get worse, making sure I don't need any imaging, anything like that. And I'll ask, see how it went. And hopefully, by correcting that asymmetry of the body and having her take some Tylenol to help with the pain, I can rid her of all of her back pain, okay? So now there's another one. I'll have you sit and face the wall. If we have what we call posterior ribs, okay, a rib that is locked posteriorly, it usually causes a tough time breathing. You feel like you can't take a full breath in. I don't know if any of you have kind of in sports got the wind knocked out of you. A rib could be pushing down and out and causing you not to be able to take a nice deep breath in. You feel every time you're going to take a nice deep breath in, your body stops you, okay? So I'm going to assess for a posterior rib, and then I'm going to use a different type of treatment called high velocity, low amplitude to force that rib back to its anterior position, matching the other ribs, okay? So when I check this, I have the patient grab her elbows and lean forward. That'll kick the scapula out of the way so I can assess this landmark on the ribs on either side that are called the rib angles. Now I glide my hands down those rib angles to find some of these ribs that are posterior. When I poke on them, you notice how she jumped a little bit. It's pretty tender. That rib that's posterior, when I poke on it, it doesn't like that. It can cause some pain, okay? I know I found one that has a somatic dysfunction, okay? So then by using other landmarks of the body, I can tell that this is rib 4 on her left side. So I'm going to have the patient lay on her back. I then position the arms in a way that will help with me in this technique. I use them for leverage. I roll her to the side to be able to find that rib that was posterior. When I poke on it again, that's the one. And so I wrap part of my palm just on the medial side, so closer to her spine than where that rib angle is. I let her lay back down, okay? And then I set her elbows on my chest. I'm ultimately going to be giving a force through her arms to that rib. Okay. Then there's a few other parts to this treatment. I have her do a little sit-up, take a deep breath in and out. And I cracked about 4 little ribs right there. There we go. So often with my hand, I have a little bit larger hand. I can find, and I can find if there are a few ribs in a row that are posterior, I can usually get a good number of them. I don't know if you guys could hear that pop, but it was a pretty loud one. So I'll have you look towards the table again. If I treated something, I'm always going to come back and assess it again. So go ahead and grab your elbows and hunch forward. And now I'm going to make sure that that spot on the body is feeling a lot better, but also when I poke on it, their pain will be gone. I corrected that asymmetry of the body. The body likes that it's corrected. Often that pain goes away. Sometimes the pain can linger for a little bit. That has to do with if there is a lot of muscles holding that rib in position. Those muscles then get a little angry that I brought them back. And so they might have a little bit of soreness for another day or two. So that's not uncommon with these treatments. So those are the 2 that I wanted to show you guys today. Those are really good ones to go through. They're 2 different types of treatments, but they both work very well for whatever medical concern the individual came in for. Now, do you guys have any questions?
Yeah, I have a quick question. So overall, would you say that like having symmetry would relieve most of the pain in most cases for patients? Do you find that to be like a key factor for a lot of the cases that you guys come across?
So that's a super good question. I'll speak to it and I'll let the others speak to that as well. One of our major goals with OMM is to bring the body back to a symmetry. We believe that the body works better in symmetry, okay? The body works better together in symmetry. This left side was having an issue with their ribs, and it could have caused pain on the right side of the body. But until we used our hands to diagnose this rib on this left side, by just giving them medication, it might stay there forever. But if we also give them medication and then treat this asymmetry of the body, it tends to help with their pain. We've seen a lot of patients come in with pain and then leave without, or within a few weeks, just by setting the body back in symmetry, it helps quicken their treatment.
And then I think just to kind of add off of what Isaac said, that was a good explanation. Not only are we looking for symmetry within the body, another big thing that we focus on are restrictions. And so as you guys start to go through, I'm assuming some of your science classes, you'll learn about what's known as soft tissue. And one of the components of soft tissue, or an example of soft tissue, is something that's known as fascia. And fascia is actually continuous throughout all of our body. And so if there's a restriction somewhere, so let's say that you have a restriction in the fascia that's surrounding your blood vessels, you're of course going to still have blood flowing to different regions, but it's not going to be as full of an amount as it would be optimally. And so with our hands, we can find these regions or these tissues that feel really tight or taut. Sometimes they'll feel fuller or warmer. And we're actually able to do additional treatments that we did not demonstrate today, just to kind of get into the philosophy of those as well. But we can alleviate that restriction around the blood vessel to allow it to be more open. The capillaries can be more open, allow more blood flow into that region, and just to provide the body all of the nutrients that it needs to fight off an infection, to allow the medication that you took orally that then got absorbed into your bloodstream to get to those regions where it can help fight the bacteria in that area.
Yeah, I mean, ditto. I think it's a pretty thorough answer. I think another thing to think about is like when you guys take a breath every day, wherever you are, you're inundated with bacteria, viruses all the time, to be honest. It's just part of living on Earth. But we don't get sick all the time. We don't get sick because we're able to breathe a lot. We're able to carry our white blood cells to an area if there is an infection. We have circulation. And we have all these forces that are able to ultimately keep things in motion. And so asymmetry can sometimes inhibit motion. Restrictions, asymmetry aside, can sometimes inhibit motion. And so for this example, say fixing a posterior rib or a rib that's stuck backwards, you're allowing the rib cage to move more and do what it's supposed to do, which is to create a negative pressure to allow air to come into your lungs, to oxygenate your blood, to provide and promote healing. So as Megan mentioned, maybe standard of care would have been ibuprofen or an antibiotic for an infection, but ultimately you're still promoting healing. You haven't done anything for that patient yet. You've attacked the bug, or you've attacked inflammation, but you haven't promoted healing yet for that person. And so OMM helps kind of marry that concept of promoting healing, and that sometimes is through symmetry or freeing up restrictions.
Awesome. Thank you guys so much for that demonstration. That was really cool. So we can start the panel style Q&A now. The first couple questions are a little bit about you guys, a little bit more personal. So the first question we have is, what interested you in osteopathic medicine?
So when I was applying to medical schools, I had applied mainly to MD schools at first, and then I had a friend who happened to be going to DMU, and so I threw DMU in there as well as one of the only DO schools that I applied to. And when I was going to different interviews for medical school, I realized that after my interview at DMU, I didn't have a headache, and I was like thoroughly enjoying my time at this medical school. Obviously, it's a super stressful time, but something about having a demonstration of, what I would be learning as a student there, and learning at that time, they had discussed osteopathy in the sense that there's a host, which is you, a human being, and a disease, which would be like pneumonia or bacteria in the lungs, equals an illness, which would then be diagnosed as, pneumonia. So it's like human plus bacteria in lungs equals pneumonia. And just kind of showing how, sure, you can throw antibiotics at a patient and you could, essentially cure their pneumonia then. But doing something, as Gabe had mentioned, for the patient just seemed like something that was a lot more personal, that I really liked the thought of then and there, being able to do something for my patient, being able to see that before and after. And one of my favorite hobbies, gardening, I guess, utilizes my hands, and I could incorporate the use of my hands into my future practice as a doctor and not just rely on, my mental capabilities, but also like physical touch with a patient was another big reason for me. So that was kind of a long-winded answer, but
Yeah. So a little different story for me. I applied to one MD school in Colorado, and then otherwise just a few DO schools. I wanted to go to a DO school, I think, primarily. I've just always had a predilection or like an enjoyment with using my hands, whether it was like working, honestly, gardening, working outside, working with pottery, I play piano. These are just like activities that are, I don't know, you have like this to you, for the lack of a better way of saying it, like listening with your hands, feeling with your hands. It feels good for me, right? So part of it was finding something that I liked, that I could see myself doing forever. And then also on top of that, knowing like, it's medicine, man. It's like complicated and challenging, and it's helpful for other people. So that's definitely why I started steering myself towards a DO school.
Yeah, I think my story is very similar to kind of both of theirs, where I applied to both MD programs and DO programs. Most of the MD ones I applied to in the Midwest. I wanted to stay in the Midwest, being from Wisconsin, as well as some DO schools. I mainly stayed in the Midwest. And then it came down to when I had offers from multiple, I had to decide, okay, what is the benefit of going to a DO school versus an MD school? And I kind of sat down, and I had a lot of family friends who were chiropractors, and I kind of picked their brain because that's what I had thought it was similar to. DO philosophy seemed to be similar to chiropractic in the sense of using your hands to help the body. I now know that they're similar, but not exactly the same. They're different in certain senses, but it clicked with me. If I can do both, why don't I go to a school that will train me in both? Similar to these guys, I have worked jobs with my hands. I was a mason for in between my undergrad years in the summer, made a lot of money that way and really enjoyed building structures. I also like to take apart and rebuild motorcycles for kind of a hobby of mine. And so working with my hands was definitely something I knew I enjoyed. And so DO school just kind of fit for me. I came to the interview here at DMU, and it was less of an interview as to why should we pick you, Isaac. You know, the school was asking the question of why should we pick you, but they turned around and made comments and made statements of here is why you should be here with us, and made it kind of a like why should I come to them for school. And so that was a different experience than a lot of other interviews I went to. And that just showed me that, you know, DMU cares. And so I think I ended up exactly where I needed to be here at DMU.
Yeah. And it's kind of interesting. Isaac brought up that point of just kind of discussing with family friends, like, oh, what's the difference between like MD and DO? Because I had a similar situation where you get accepted into, you know, an MD school and a DO school. It's like, well, what's the difference? Now you really have to compare, like, well, what's the difference, right? And at that point in time, and even for you guys, when you go on and you apply later to medical schools, if you get accepted to multiple schools, you need to ask yourself first and foremost, like, where are you going to be happy for the next 4 years? Because it's not an easy time. So you need to ask yourself that. So when I posed that question to myself of this MD school versus DO school, I just reflected back on when did I enjoy myself the most during that process? And that was when, obviously, I'm here today. So I selected DMU.
Awesome. Thank you guys very much. So we have one quick question in the comments, and it was, what are other specializations that are available for DOs?
Yeah. So really being a licensed physician as a DO, you can go to any specialty that an MD can. There's really no limitations. And so that's kind of the quick answer to that. And so because you come out and you take very similar boards, if not take the same exact boards that MDs do, you have the choice to either take both or just the DO boards. But you can go into any specialty that an MD can. There's no limitations at all.
Sure. And then kind of going off that a little bit, I know you guys talked about the OMM fellowship that's between the 3rd and 4th year. Could you talk a little bit about how that process works? Is there any like financial benefit to that? And like maybe a little bit about, how that application process works?
Sure, yeah. Some forward thinking there, for sure. So the fellowship works like this. It's a year of teaching. So you're an employee of the school. So you're working for the school and you're like staff. It means you got paid, you're getting paid for that. And then in addition, you're normally going to pay for 4 years of med school. You just don't pay for that 4th year. So you pay for 3 years of school, and then you get paid while you're an OMM fellow. And then we get stipends for their research or travel to conferences. Application process is about demonstrating why you want to do it, why you enjoy OMM, what about the fellowship it is that you wish to, why it is that you are using the OMM fellowship as like a springboard for your career, and why that interests you. You've got to be able to demonstrate that. General application process, I think like anything else, you answer questions, write an essay, give a personal statement kind of stuff, and then you have an interview with the whole faculty. And you have to, which is like about 15 people, you sitting at the end of a really huge table, and then just like, getting interviewed that way. And you have to teach. So you have to demonstrate things and demonstrate your ability to teach. In addition to like classic, both obvious and left field questions, yeah. Does that answer your question?
Yes, that does. And then I guess, do you know how many people get accepted every year into that fellowship program? Just so we can kind of have a number for that. 4 people out of a class of how many?
220 students in our class, and 4 get the opportunity to be a fellow.
So there's as Gabe mentioned, the application process, and each year the amount of applicants kind of varies, but every year the selection process is the same. There's only 4.
Well, big congrats to all 3 of you. So,
Good, thanks.
next question. How does the DO curriculum compare with like an MD curriculum?
So I think just like the most simplest way of answering that question is they are the same, except DO curriculum has to teach you OMM. That is probably like from there you can talk about nuances, and every school is gonna be different than other schools. But so I took both the like MD board exams and the DO board exams. In the future, that may be less and less and less necessary. The residency programs have joined, and they're seen as equivalent programs now, M.D. and D.O. But yeah, there's just like people catching up and figuring out their algorithms, how they choose and select people. So I was able to take those exams, right? And so you can't really be a doctor without learning like the medicine you need to learn. So they're ultimately, it's the same. I would say that there's influences with OMM, that you have a really, really, really strong background in the ability to communicate and even just like actually touch and do physical exams has been a benefit. Anatomy is a really, really important aspect of OMM. And so therefore, you get a pretty like just such a good anatomy experience, I think, at most DO schools compared to MD. But you know, again, didn't go to an MD school. I'm sure they have good anatomy programs, but it's you know, the use is the glue. You forget, you have to learn so much in OMM, or sorry, in med school, and then you forget a lot too. But I know, but because we do so much OMM, you learn so much anatomy, and it sticks with you.
Mm-hmm.
Did you see that question pop up? I think I saw a question pop up in the chat. And the question was, sorry, what was it? It was,
can an MD get licensed
Yeah.
in OMM?
so you can go to an MD school, and then in your residency years, you can learn under a DO faculty member or another resident at that residency that then can teach you OMM. And that is a different route to go at. And many MD physicians have taken that route, where they got into an MD program. They had no idea what OMM was. They really realized that it could benefit their patients, and they decided that they wanted to learn more about it. So just because you don't go to a DO school does not mean that you will never learn it in your life. It's just at a DO school, it's already in your curriculum. And so when you come out with your doctorate, you're going to already know it, versus having to take the time during residency to learn that extra trade. Very good question.
That was a good question. Thank you, Tina K. So the next question I have is, how does the DO application process compare to the MD application process?
In terms of medical school, it's been a while since I applied, but I know that there's two different systems. So for MD schools, you use system A, and then for DO schools, you use system B. You upload your transcripts and resumes and whatnot. As far as the application process, it's really just having to utilize both of those sites to apply to both of those schools. When you go to interview, it's the same questions, right? And then in addition to that, hopefully they give you at least a demonstration of the OMM that they do at their school. That's something that's typically normal process here at DMU, and I think it just sheds some light onto, what osteopathic medicine is for students that are interviewing and have yet to learn the whole philosophy behind it. But as far as I know, that I can remember, there's really no major difference.
I mean, it's that same mess between the both of them. You gotta like get all your curriculum or your transcripts together, send that in, right? Then you gotta get letters of recommendation, send that in, answer some essays, send that in, and then do interviews. So in that respect, it's no different.
I just remember, I think there is one difference. Some DO schools that I know of actually require one of your letters of recommendation to be from a DO or that doctor of osteopathy, so that they know that you have some exposure to it, or you have kind of an idea of what, that school or that education entails. And so really that you can just get a letter like that through shadowing opportunities. I think that was one of the ways that I had gotten mine, or just through internships over the summer from undergrad.
And for both schools, you're going to need an MCAT score for a prereq to both schools. So that's going to be part of that process. DO programs and MD programs look at that score as well.
Gotcha. Thank you, guys. So my next question is kind of two parts. So what does medical practice look like after obtaining a DO degree? And then also, do you guys know of like a percentage of people that practice OMM after they get like a DO degree?
Mhm.
Yeah.
So what practice looks like after you graduate medical school and go into residency as a DO looks exactly the same as that as if you're an MD. It's just that in addition to doing your regular residency stuff, you can quickly do what's called a spinal sweep, see if someone has any twist or turns in their back while they're seated or supine, and see if that contributes to your medical diagnosis. There's really no difference between the two of how you practice. And so I'm not sure really how to tease that out too much, unless you go into a field that's going to be more specific to like OMM, or if you want to add a little bit more. I can't really think of any differences at this point.
Yeah, there's really not. It's just an added part to your physical exam that we call an osteopathic structural exam, which is exactly what I did up there, which is finding that posterior rib. An MD might find that rib by glossing over and saying, oh, this part is tender, this part is painful, but they won't really know what to do with it. And so they'll just mark that down on their physical exam and then look at that later. But for us, we'll see that and we might be able to then tease out and treat that area. And then we put that in a little different section of our physical exam. But otherwise, both office visits with a DO or an MD are going to look exactly the same. We'll just be able to provide that OMT if we deem it necessary for that patient.
Gotcha. Let's see. What residencies tend to be favored by DO students or DO people with DO degrees?
So I think if you look at the stats, which I don't have in my brain, but just like generally speaking, a lot of DO schools have a lot of students that go into family medicine. That's just like statistically true.
I think here at DMU, there's been a recent trend of a lot of students going family medicine, so family medicine, emergency medicine, and then internal medicine. There's been a kind of a shift of just sort of branching out where it's broadening more and more. We've had a couple students, or another theme last year was a lot of students went into like anesthesia. A decent chunk went there. We had a handful that went into ortho, actually a bunch that went into general surgery. And then you can kind of branch out and specialize from there. There's some that go into psychiatry. Really, any residency you can think of, it branches out. But I'd probably say the four most popular would be family medicine, emergency medicine, internal medicine, and then I think it's a toss-up between surgery and anesthesia after that. From the most recent stats I looked at, which was a couple weeks ago. So. And
with an entire class of 220, there's going to be a mix, just like any school. And so some will go to, it kind of spreads out. But yeah, the primary care are kind of the primary ones that a good chunk of the class goes towards. And then I do want to add the second part of your last question about how many doctors typically use OMM in their practice. I don't really know a percentage. I can't come off with a percentage in my head because I don't think we actually know. We don't do a lot of polling. I do know that out of the DOs, there are some that feel strongly for it, that it benefits their patients. And I know that some feel like it doesn't benefit their patient at all, or they leave the DO school and then they forget a lot of the stuff that they learned. And so they don't feel comfortable providing it to their patients. Ultimately here at DMU, we want to set you up so you can provide it. We set you up with a nice thick workbook by the end of the 2 academic years that you can reference and go back to and look at those treatments that we taught you in those first 2 years. So our goal is always that you use it with no matter what specialty you go into, but I can't really talk to a percentage. Yeah.
Gotcha, thank you. And then the last question I have for you guys before I open it up to everyone else is what is something that you would have done differently in undergrad or is there any advice you have for, pre-medical students that are soon to apply?
I think
I'm imagining that this question comes from a place that is also asking us what would we do differently to get into medical school or make the process less stressful or to do it better. Because I like reflect on that question, I'm like, I did fine. I was happy with the way I did it. I got here, and it wasn't like the most straightforward way. So I didn't know I wanted to go into med school when I was an undergrad. And then I had a degree in in psychology and cognitive neuroscience. So like I was thinking of going into maybe research. And then I was working at the bar for a couple of years, and then I was scribing for a couple of years, and that's when I started making my way towards what I wanted to do. All right, so from that perspective, ways to make it easier on yourself is like, obviously, if you know what you want to do, that's just like, whew, that's so nice. If you know what you want to do, then you can do all the things that make it easier to get into the program. Something I could have done to make it better or like quicker was like decide that I want to go to medical school way sooner, but that didn't happen. So what would have I done with that knowledge? I would have definitely tried to get more involved in research. Applications love doing research. Getting shadow experiences early on. Applications love that. Volunteer experiences. I actually had tons of that, but like having tons of volunteer community service, just demonstrating, making an impact in the community. These are all like key, wonderful things to make it really easy to get into schools. Good grades, always a thing. And then had I known, right, that I want to go to med school, a lot of that like science and biochemistry, all that stuff would have been, in physics would have been real fresh in my head. It wasn't. So I had to study a lot more for the MCAT, right? So having like all that like pre-med knowledge packed up and ready to go, and then like putting it out on the MCAT is going to help you out. Volunteer, shadowing experiences, and getting your hands on some research if possible, if that's what you're interested in.
Mm-hmm.
Yeah.
And then just kind of from my perspective, the first thing that comes to mind is that when I was going through, so I have a major in biology. And so when I was taking all those biology classes, I think the common, or what I thought was the common trend, was that people would take the MCAT right around their junior year, apply to medical school right around your senior year, like leave campus for interviews and whatnot, and then go straight through to medical school. Actually, what the common theme is nowadays is that people are taking gap years so that they can actually live a little bit of their life. And sometimes when you're a pre-med student, typically students tend to be like type A, you want to get in, you want to get going, you want to get on with your career. But I also think that it's really good to reflect back on the fact that it's also really good to live your life a little bit. And so if you feel like you want to take a gap year, that's totally fine. That's what I ended up doing is I took a gap year. I studied for the MCAT in the beginning. I felt way less stressed about having to study for it versus during that junior year. I studied it more for it towards the end of my senior year. I felt more relaxed. I felt like I was able to I was not going to say it was an enjoyable process for studying the MCAT. I'm not going to like sugarcoat it. It's not fun. But just having that year to kind of, this is so cliche, it's just like grow as a person and just like do something I knew I wasn't going to be able to do later, was just like refreshing. I felt like I wasn't going to be burnt out because medical school is hard. Like it's not easy. Undergrad is not hard. To get a biology, chemistry, biochemistry major, whatever you guys are going into, it's not easy. It takes its toll on you, mentally. You might feel good, but when you're studying every day for so long, you want to be able to kind of reflect back on, all right, why did I do this? Why did I go into this? And you can have those reasons within your gap year, or even those experiences you had volunteering or shadowing, or scribing is a really big one that a lot of programs look for, because when you're scribing, you're seeing medicine right then and there. You're actually a part of it as you are documenting for the doctors. And so I feel like I'm kind of rambling at this point, but I'll probably just stop there and throw it over to Isaac.
I personally think that those are all great points. I think that I did take a gap year as well. I scribed during that, and so that's a great way to get yourself thinking about the medical terminology and just picking the brains of different doctors. Finding a good mentor is another good thing. whether that be somebody you can shadow multiple times. To shadow once is one thing. You can kind of get how maybe a normal day is, but I would encourage you to shadow multiple different doctors and multiple different specialties and try to do it more than just one day. I also want to just speak to you. To make it through a very tough medical school, you have to have balance. Be able to balance a very tough schedule. And so if you can show them that you can balance a tough schedule, you're going to undergrad, if you have a job, if you're doing research. I know a lot of people who solely like to focus on one thing and they're great at it, and that's awesome. That works for them. But sometimes in medical school, you can't just solely work on one thing. You have to be able to balance. And so I think if you can show a medical school that, hey, I was in research as I was working, as I was taking classes, and I shadowed on the side, it shows them that you're ready to balance a lot of tough and stressful situations, and it looks good on your application. And it also gets your name out there. If you can find that mentor that way, and somebody can vouch for you that, yeah, you're the real deal, and you're going to be a great physician someday, you just need some guidance. They'll stamp their name on your application, and you know, you're that much closer to getting into a medical school.
Awesome. Thank you guys for the great advice. We have about 5 minutes left. So if you guys have, if you guys have any questions, feel free to unmute your mic or ask it in the chat. We do have one question in the chat from Tina K, and that is, do a lot of your patients understand what DOs are and what they do?
I think the benefit of the recent news and just kind of broadcasting of DOs, it actually more easily sparks that conversation. And so, granted, we work within an OMM clinic right now. So a lot of the patients that are coming in know that they're going to be treated with our, while their doctor is using their hands. But while we were out on third year rotations, when we would go into the room, introduce ourselves as third year DO students, doctors of osteopathy, sometimes, patients would ask. I would say that the majority didn't necessarily know what a DO was. And then they would look at the letters behind their doctor's name and be like, oh, wait, you're a DO? And they had no idea because maybe that doctor just didn't practice OMM. And so I would say that the majority don't know what DOs are, but they also don't necessarily take the time to look at the letters of the last name.
Gotcha. Who else has some questions?
I got a question. So I know for Carver, for example, they work with a lot of other health personnel, such as like PAs and nurses and what have you and everything like that. Do you guys find that to be an important concept, like teamwork and everything like that, for DO as well? Like just being able to work with anyone in a hospital setting for patients? Is that like a common theme as well?
Yeah, that's a great question, and that is unbelievably true. Yes, having that teamwork mentality, I am one key to the puzzle. I am only as good as my weakest link in my team, and so to empower your entire team to be better and for your patients is ultimately, my goal. And so, yeah, my wife is a physical therapist. Here at this school, we have physical therapy students. We also have PA students, and we have Masters of Anatomy students. We have podiatry students. So some of our classes in our first year are actually combined classes where we'll have PAs in with them. We'll have not a lot with PTs, but we'll have classes with podiatry students. And you do get that mentality of, hey, they're learning the very similar things to us. They're going to be a great asset sometime. And I'm not going to be scared to talk to them when it comes to us in the same hospital working together. I'm going to feel comfortable that, we can all work together. And that's definitely a big part of medicine is being a team player. And your patient is also part of that team, and never forget that. They have just as much say, and they have the final say. And so to be able to, have a full team and then get that patient on board with the entire team to empower your patient to their full health, that's ultimately, our goal.
So DMU has had multiple seminars with other schools throughout Des Moines and beyond with students from dentistry, from pharmacy and nursing schools that we go through patient cases. And so I think that integrative medicine is a model that DMU has promoted for however long, longer than we've been here. But then also that model needs to be not just emphasized at schools, but emphasized, in the hospital or the system that you work within. And so that integrative model is becoming more and more mainstream, just to kind of close that gap between, or honestly, the pitfall. So one of the biggest pitfalls in medicine is a break in communication and like that handover of patient care. And so having integrative medicine is something that is modeled here in the school, but also it's just becoming more and more widestream. Like it's like that question eventually, hopefully, won't even be a question someday.
Does anyone else have any questions? If not, I just want to give you three another big thank you. I know that, of course, since there are so many MD schools and it's such a popular program that a lot of pre-med students, they go through their 4 years of college without really knowing how, knowing much about what a DO program is, what a DO degree is, and how similar they actually are to an MD program. Rather than different. So I appreciate you guys taking the time to come and kind of making everything concise for us. So thank you guys again so much for being able to make it.
Yeah, no
Absolutely.
problem.
Yeah.
We're happy to talk about it. And if you have further questions, feel free to email us.
Yeah.
We're always here and happy to give you our input on stuff. And yeah, good luck to all of you.
Thank you so much. Take care, guys.
Yeah.
Thanks.
Thank you.